Hi, and welcome to YP-CDN's Town Hall today. We started the Town Hall a few months ago, and this is really the second one we've had. Um, and so the concept of a Town Hall is really to have everybody in a community come together where attendees can present ideas, voice their opinions, and ask questions. And so since we can't all come together in one physical space, we're coming together in a virtual space. And with YP-CDN, the idea of this town hall is really for you, our members, to better understand the mission and activities of YP-CDN, what role you can play, to better connect and get to know other members of the network, and to hear how we can continue to create and maintain a successful, engaged community organization. And so each session will also be around a specific topic or theme to have a discussion on and push the NCD advocacy agenda. So those who are new to YP-CDN, we're a global multidisciplinary community dedicated to policy analysis, advocacy, and social change for non-communicable diseases. And these include cardiovascular disease, cancer, diabetes, chronic lung disease, and mental illness. And so our vision is really that our generation create a generation of change, one where a world where all people have the opportunity to lead healthy and productive lives. And so our mission in line with that is really to mobilize this global community to take action against social injustice driven by NCDs. And so as members, we really want to provide you with a platform and tools to drive change in your community and to tie these local efforts to global policy discussions. So YP-CDN serves as a bridge between the local and the global by enabling local action on NCDs and building global impact and accountability. And why are we emphasizing NCDs as a social justice issue? Well, because they cause millions of preventable deaths, particularly in less developed nations. They disproportionately affect impoverished communities and lock people further into poverty and cause catastrophic consequences for individuals and societies alike. And so our focus as an organization is particularly on access to NCD medicines. And there was a new UN high-level panel on access to medicines that was just recently announced, and that met a few days ago. And the high-level panel also noted that despite progress made in many areas, millions of people are still left behind, and many are dying because they can't access life-saving medicines. And so a lot of this discussion on access to medicines and the actions have really been in the area of HIV/AIDS, TB, malaria, and increasingly we're seeing or hoping to see a focus on non-communicable diseases on the global stage as well, not just for low-income countries where it's definitely needed, but also there are issues in accessing affordable medicines in high-income countries for diseases like cancer. And so in terms of the policy, global policy discussion, I'm going to just go into a little bit more discussion on the global policy, and then I'll get people to introduce themselves, and we'll launch into a discussion and hear from Sunny, our board president, about essential medicines lists and how we're looking to build activity on mobilizing essential medicines globally in that regard. So the WHO has an NCD action plan that serves as a sort of a blueprint for countries to utilize as they take on NCDs in their countries. And so this action plan has 9 targets to reach by the year 2025, and one of these targets is to achieve 80% availability of affordable basic technologies and essential medicines, including generics required to treat major NCDs in both public and private facilities. However, the most recent data that we have, or that is available, shows that only there's only 36% availability of NCD medications in the public sector, and this is compared to 53% of acute medicines. So neither are at the stage that they should be in terms of availability and access, but we still have a really long way to go in terms of providing sufficient access to NCD medicines in many cases. And there's also evidence that these medicines for NCDs are less affordable, and in many lower income countries as well. And so, for example, a study from India showed that an estimated 600,000 to 800,000 people were impoverished by the costs of caring for cardiovascular disease and cancer. And one interesting stat that I found out about the other day was actually that 85% of medicines in Kenya are 4 times more expensive than medicines in the UK. And so the question is, why is that the case? And how can we make sure that we change the global situation on NCD medicines? And so that's where I really want to jump into sort of a broad discussion with everyone today, and tie this in with what we currently have going on called our Multiply Change campaign. And so what the Multiply Change campaign seeks to do is to raise awareness of lack of affordable medicines for non-communicable diseases, particularly in low and middle income countries, but specifically to raise funds for our NextGen Leaders program in Kenya. And so our NextGen Leaders program is a train-the-trainer program where we prepare our members of our network to mobilize their community to change policies and promote social change so that medicines for cancer, diabetes, and other diseases will become more affordable and available. And this change is very much possible. We have interest of support from the Kenyan Ministry of Health, from WHO staff who work in essential medicines on the technical side, and we have the experience to deliver this training on advocacy strategies and how you can really win changes in policy. And so I'm going to leave it at that, and would love to hear comments and questions from you in relation to our campaign as well. But maybe we'll start off, and I actually wanted to do introductions earlier, but we'll start off and launch some introductions. So maybe we can start with Sunny.
Sure. Hi, guys. I'm Sunny Kishore, president and founder of the YP-CDN and a public health advocate at Yale right now.
Thanks, Sunny. Okay, what about Casey? I think Casey's not able to speak because she's at work. So we, Deanne, do you want, so Casey, I'll introduce Casey. She's our social media coordinator, a volunteer social media coordinator, and she's based in Madison, Wisconsin. Deanne, do you want to introduce yourself?
Hello, I'm Diane. I'm a CC fellow with UAM and the scientific and technical advisor at KI.
Thanks. And just go ahead, the rest of you, Ishu, Sam.
Hi, I'm a medical student from Hong Kong. My name is Sam Lee. It's really nice to be here today. I'm also with the UAM team in Hong Kong, so thank you for inviting.
Hi, I'm Ishu Kataria. I am the Global Coordinator for YP-CDN, and I am a Senior Research Fellow with University of Delhi in India.
Great, thank you. And I see we have a few viewers who are viewing live who haven't joined the live discussion as well. So you can insert any comments or introduce yourself in the group chat and ask any questions that you have as well. We'd love to hear from you. So do we have any, Sunny, do you want to start off with the essential medicines concept and the essential medicines lists?
Let me know if you guys can hear me and see me. Yeah? Okay. All right, guys. So yeah, I'm Sunny. So Jordan asked that I talk through just a little bit about the essential medicines concept at the WHO and some of our activities on that. But before I got into that, I did want to make this just a bit personal because I think too often in the NCD space, I think we see people not being personal enough and telling their kind of story of how the NCD issue deeply affects them. So for me, I came to this space from malaria. I actually lost someone very close to me from cerebral malaria about 17 years ago. I was ill myself. I had high fevers and was semi-comatose and the whole 9 yards. And I really am here because I had access to essential medicines. And so this, to me, is not academic. It's not just sort of pie in the sky. It's really about life or death. And that disparity in access, whether it's for a person who has cancer right now or someone who needs treatments for high risk, high cholesterol or has heart disease, this is very important. I thought I'd tell a story that I told before, and it's adapted from some comments I just gave at the WHO. And in the story, I'll try to introduce the essential medicines concept and where I think we're headed. So the way that I introduce this is I start off with a date. And that date, to me, is really important, and I don't think a lot of people know about this date. May 8th, 2015. May 8th, 2015. This was actually a fairly big day for people living with NCDs, and I think it was a big day for YP-CDN and our allies. So on this day, the World Health Organization added 16 life-saving and life-affirming drugs for cancer on its essential medicines list, or the EML. So what in the world is the EML? What is this concept? So the bottom line is the EML is a listing of the highest priority medicines that should be available and affordable in a community. Available and affordable in a community. And per the WHO, it should be available at the cheapest prices possible, if not for free. The cheapest prices possible, if not for free. So it is a human rights tool and a key lever for universal health coverage and realizing some of the sustainable development goals. So I first heard, so going back to narrative and human rights, I first heard about this EML, it's a really technical tool, in 2002 when HIV treatment advocates petitioned the WHO to add high-cost patented AIDS medications on the essential medicines list. So this was an important move. So this campaign, among other decisive moves, helped lead to 90% price reductions in these drugs. There were key things, if some of you come from the sort of global health or national trade space, the invocation of the Doha Declaration, which provides a legal basis to make medicines accessible as a human right, were a crucial part of that strategy as well. So I'm really proud to say that if you're new to the YP community or the Access to Medicines community or the NCD community, I have to say that members of this community, I stand very proud, have modernized the essential medicines list over the past 8 years. So we took a hard look at the list 8 years ago, or even almost 10 years ago now, and realized that there was a heavy skew on acute diseases, which Jordan was mentioning, sort of malaria, pneumonias, infectious diseases. But we had not modernized the list as a fundamental equity right on non-communicable diseases. So we went after blockbuster statin drugs in 2007. We went after modern beta blockers in 2011. And we went after drugs for mental illness, a blockbuster drug called risperidone that we use very often in the United States here for psychosis and schizophrenia in particular. And in 2013, we and our group here, along with allies with Knowledge Ecology International and Universities Allied for Essential Medicines, and another independent group called the Union for International Cancer Control, petitioned the WHO to add 2 medicines to the essential medicines list for cancer. One was imatinib for leukemia, and the other was called trastuzumab. It's trade name is Herceptin, and it's a biologic for a selected form of breast cancer. So the kind of story here, why this was a big deal, is the WHO at the time reviewed the petitions and said, you know what, we can't add the medications. And there were reported concerns on cost effectiveness, and so forth. And then something actually happened. These petitions from these two groups triggered a review of the whole cancer section of the essential medicines list. And this is where I'm very proud. So inspired evidence-based leadership by treatment advocates affirmed that a medicine should be deemed essential based on clinical need and not cost. That is, affordability should be a consequence, not a precondition for being qualified as essential. And this is important. So in a surprise move, then the WHO actually agreed and added not 2 but 16 total drugs for cancer on May 8th, 2015. And I have to say, several of these were patented and cost nearly $100,000 per patient per year. So now you sort of have a very real question balancing human rights and individual rights of patients to access medicines against sort of public health and cost effectiveness and what people deem as rationing, right? So, you know, in HIV, we blew right through this. We didn't let these discussions detract from the debate, right? So, and as Jordan mentioned, though, with NCD drugs, including for cancer drugs, especially for cancer drugs, we're at very low availability, and affordability is not even, these drugs are simply too expensive for many people. A lot of people are paying out of pocket. So we're far short of this 80% availability goal. So what happens now? So what happens after medicine gets on the WHO essential medicines list? So it's deemed essential. It's deemed to be affordable and available for a community at the cheapest price possible, if not for free. Now what happens? Well, countries adapt the international list for their national context. So a country, say China will adapt the international essential medicines list for the Chinese essential medicines list. In the case of China, these medicines are linked to price ceilings. So no medicine on the Chinese essential medicines list can be above a certain price. In certain countries, any medicine on the national essential medicines list is guaranteed to be free in the public sector. On the demand side, all UN agencies restrict their drug donations to medicines that are only on the WHO essential medicines list. So availability is nearly 7 times higher for medicines that are on the WHO essential medicines list as opposed to medicines that aren't. And if you're just curious, we did an analysis of one of the medicines we added, statin drugs, in 2007. We just wanted to see, did countries actually care? Like who's actually being held to account here in terms of changing their own list and their formularies? And it looks like 7 out of every 10 countries surveyed after statin drugs were added in 2007 added these drugs on their essential medicines list. Does this mean that they're being provided at a cheap price or for free in the public sector? That's a part of the analysis where YP-CDN and other groups want to get into for our next step. So, you know, I just want to sort of talk about learning from the HIV/AIDS experience. There was real accountability and demands for these drugs. And there are core lessons that I called the 3 C's to close the gap. And I think there are critical lessons to learn from that experience for us. And I'm hoping the folks on this hangout and folks in our community will sort of take up that challenge to really mobilize and stand up for patients living with chronic disease. Right now, we are failing. So the 3 C's are coordination, cost, and change. So the first C, so the bottom line in our view, is there is no real global coordination on NCDs, especially on essential medicines. At the WHO dialogue that Jordan and I were at 2 weeks ago, you know, there's a whole meeting on the global coordination on NCDs. An ambassador from Sierra Leone affirmed that the poorest countries, the bottom 36 countries, the least developed countries, cannot afford to scale up treatment by themselves. That no domestic tax on tobacco or sugary drinks will ever do the trick in Sierra Leone. So patients with cancer. Sorry, I got some feedback. So the bottom line there is there needs to be a platform for countries to actually procure and disseminate and distribute these drugs. So, and we would argue that a platform potentially hosted at the WHO is a very important next step to help realize and implement the concept of essential medicines as a human right. An easier way to put that is, what is the point calling an essential medicine essential if it is not available and affordable for people? The second point is cost. So we believe that for NCDs, and especially in the case of cancer, that intellectual property and trade provisions are meant to protect companies and not people. And here we follow in the footsteps of leaders in the HIV/AIDS movement who argued for trade flexibilities to help countries access these high-cost NCD medicines. Now, I do think, and this is a key point. I mean, I'm seeing people from Hong Kong here. I know we have people that we're trying to partner with in Kenya, as well as India on the call right now. You know, we don't have a great sense on how much these drugs cost. You know, a movement on drug price transparency on the NCD front would be incredibly important because there's simply has not been a lot of focus on this question. The last thing is, and again, this is a critical role for a group that does policy analysis and social change, is the last C, change. So a Director General of the WHO, Margaret Chan, spoke at this meeting, and she highlighted accountability and the critical role of civil society in driving the NCD response. And this is an important area for us to really think about. If a drug is deemed essential at the WHO level, who is meant to hold a member state or government to account to provide that medicine at the cheapest prices possible? I mean, is it us? Is it civil society? Is it the government? Is it the private sector? I mean, who is it? And so I think this is a question that we really need to confront, is when and how are we going to use these basic human rights tools like the essential medicines list to realize the concept of an essential medicine to safeguard our health? Our point, and I was delighted to see that the Lancet and Richard Horton affirmed this, is that NCDs are a social justice issue of our generation, and therefore they need to be treated as such, and we need to back this up with coordination, reducing cost, and driving social change. So I'll kind of leave it at that, and I'll turn it back over to Jordan.
Thanks, Sunny. That was a great overview, as always. So I just wanted to see if there are some reactions from those on the call in terms of essential medicines and NCDs and what we've just spoken about. I mean, I wonder, Sam, if you can share any insight on the situation in China and how the essential medicines list works.
I'm just thinking, you mentioned something about the drug price, and I'm thinking because one time I was helping a friend doing some sort of research about the price of entecavir in the anti-herpes antiviral in different provinces of China. So what we found was that the prices are available online in databases that are available for buyers, and most of these websites are actually not in English but in traditional, in simplified Chinese. So it is virtually impossible for someone who doesn't know the language to know what exactly the prices that it might play in different provinces. So when I was also working in UNRWA in Jordan, in the Middle East, we also faced some problem about finding out the exact price, because most of the information might not be available in English. It might be available in Arabic. So I think language barrier is definitely one problem here if we want to have sort of like a transparency of the drug prices. So this is my first reaction.
Mm. Mm.
Thanks. Sorry. I was just saying transparency of medicine prices is a huge issue, obviously in many different settings, and So there's some questions, what can we do to increase transparency of medicines? And is that, I think what the situation we're at is that the biggest barrier? The knowledge of what these medicines cost and then ability to negotiate from governments and the procurement side. Because I'd love some more discussion and thoughts that all of you have. Deanne? Or Sam, yeah, go ahead.
Yeah, I just want to follow up on your comments because when I was working in the essential medicine program in UNRWA, the senior pharmacist taught me that basically when they do procurement, when they try to look for the best price available, it's really about marketing. But if we don't have transparency about like what exactly is the prices around the region, it's basically impossible to technically have the best price. So I think that's why I think it's also important.
Mm-hmm. Any other comments? Ishu, do you have any insight on the situation in India in terms of price transparency?
I think the problem that has been highlighted also is in case of India, because there's a huge variability in the kind of price transparency that we are facing in India. But specifically for New Delhi, I can tell you we have AIMS. It's a huge hospital. It's a government hospital, and they have a generic pharmacy. But the number of people that actually get the medicines actually are very few, because there's a limited time slot and they come from all parts of the country. So even if it's there, it's very limited and not many people are able to actually access it who need it the most. So what they're forced to do is to buy it at a higher price, which is available outside, because the other person who's selling it knows that it's actually required by the person in need. So there's a lot of discrepancy in terms of prices. That's a situation also in case of India, yeah.
Great. Feel free to jump in. Deanne, do you have any sort of comments from your experience or on the IP side? That is a no. Sunny, do you want to follow up with any comments on price transparency and how that could potentially be tied to our efforts for the EML?
Yeah, I mean, I think it's a really good point actually in terms of accountability, because it's something that people can actually do. Imagine this. I think one of our colleagues, Raj Vedantan, he had an idea a while ago called WikiMeds, and it was sort of like it wasn't really a WikiLeaks for medicines, but it was basically an open access wiki where you could post the sort of key prices that you are seeing in any given community. It'd be really interesting to do this regionally at some point. The Management Sciences for Health has something called a drug price indicator guide that gives you the lowest, or it gives you tender prices or procurement wholesale prices regionally. So we know right now that statin drugs, for instance, are like $6 per patient per year, down from $1,200 per patient per year years ago when they were patented. And so I think finding positive deviance, meaning finding places and regions where we know the drug is really dirt cheap and we know the generic suppliers, and there's a range of allied organizations that work on this, I think would be really powerful in the case of something like cancer, is to embolden a market for generic cancer drugs, for instance, prove that there is a way to get them at very low cost, and then try to scale up things like voluntary or compulsory licensing to ensure that the drugs are low cost. I think that'd be quite powerful. The other side of this, I think, and I'd be really keen for what people think about this, is right now, as I see it, there is no appetite at all for funding these drugs in an international setting. Meaning each country is being told that there's no expansion of the global fund, we're not going to create a new global fund for NCDs, et cetera, et cetera. So any responsibilities that you have to your populace of treating cancers or heart disease, making insulin available, is your responsibility with your health budget. What can a country with $19 per patient per year do alone? So I think transparency fits into this, but I'm also curious to know of how do we actually, with existing essential drugs on the essential medicines list right now, where does our organization fit into holding our governments account, but realizing our governments can't do it all because they simply don't have the resources? So where does that come from? And this has been a stalemate, a checkmate, where for the past 4 years we've had this conversation in the NCD community, the public health community. And so I'd love innovations or thoughts on ways to actually realize the essential medicines concept. It's because otherwise we'll just be stuck at this stalemate because there's no new resources coming in.
Sunny, do you see some of the comments in the group?
Oh, okay. So this is from Sam. I have a question. Do you think the market policy in China for essential medicine is a good practice then, if exact price is not? It's interesting. I don't know. So Sam, can you clarify? My understanding in China is that the price ceilings exist for all essential medicines. Can you verify? Like, is that accurate?
I'm not an expert in this actually. I need to clarify.
Okay.
But I have also heard about this market policy. So what they do is that they have the list, and then they in different provinces they unify that within China there can't be the setting of the price available for patients must not be above certain prices.
Right.
So this is actually some interesting debates within the country because it actually affects the profits that doctors and healthcare providers can make in certain provinces. And so I'm just wondering, so I'm a little bit unsure whether this is a good practice. I mean, I'm wondering, is there any similar example in other countries? Is this a good practice?
That's super interesting. Ishu, this might be a question for you. I've heard that in India there was a discussion of instituting price ceilings and price controls on essential medicines. Do you know if that's happened or not?
I'm not really sure about that, Sunny.
Okay.
Not really sure.
No, it's interesting, Sam, because I don't know. I mean, I'm sure there's a range of other countries that have price controls, but I think China is fascinating because of the sort of scale of the problem, and it's a huge burden in that country. So I think this is a good excuse for us to all actually scope out some of the implications on this. I think your point about the profit for doctors is a really good one, because this is, and I'm seeing Deanne commenting on what's doctors' role. I do think that not just doctors, but all health professionals have a deep role to hold governments account to price transparency and reduce cost. But the dirty secret is, and if you want a very concrete example, the American healthcare example, which I participated is one. Doctors have no incentive to do so. There is in a sort of reactive, episodic kind of acute care model, there is still very much not collusion, but you actually generate some profit from the way that you work together with drug manufacturers and what we call relative value units, or RVUs. So I think it's really interesting to find a strategic way to get doctors in a place like China activated on behalf of their patients on price transparency. I imagine that's quite political and touchy, but it would be a fairly important movement. Deanne, do you want to share what you're commenting? Okay. Okay.
Hello?
Hi.
Hi, sorry.
Typing away.
Yeah, I know. It's because I'm at work. Just regarding local manufacturing, if more, just, I mean, is this what you wanted me to comment on?
Anything.
Well,
whatever you're typing.
With regards to that, then it's just a very out there kind of idea. But if more countries had more capacity locally to manufacture essential medicines that they need, because I was also thinking about all the TRIPS barriers and like how to bring the meds into the countries at affordable prices, and obviously all those things affect price, and there's not a lot of knowledge sharing when it comes to manufacturing. And now that a lot of these countries are really beginning to have sending their youth to universities and all these things. I mean, there's like a lot of brain drain and all these things, but this might also be an opportunity to bring these young minds back home and to be able to capacity build their own pharmaceutical manufacturing for their own country's needs.
Yeah, no, I think that's really actually. I mean, I think about something like insulin, right? So I've been introduced to this problem the past 2 or 3 years. So effectively, 3 companies have nearly 100% market share on insulin. It was discovered. I think the Canadians all know this, but it was discovered in the 1920s. Got the Nobel Prize. It was actually a medical student. I think he was a medical student or graduate student, Banting and Best, working. Yes, okay. Thanks, Jen. Yes, exactly. Banting and Best, right? And still today, we don't have a clear source of generic insulin. And I've heard of one group, I think it's out in California, that's trying to come up with an open access kind of off-patent supply of insulin. But I think to your point, why is this being done in California? Why not India? Right. And they sold the patent to U of T for $1. Exactly, right. And now we have this life-saving drug for type 1 diabetics and now for type 2 diabetics that is simply not available. So imagine a place, imagine CIPLA, or imagine a group in Rwanda or East Africa that could produce these medicines. And exactly what Dion is talking about in some of the provisions, or I think the dreams of the TRIPS agreement years ago, was to start to build and transfer that technology and knowledge to get local capacity and pharma production going. It's been fairly good in South Africa. UAEM has had a great story with Aspen Pharma that made low-cost antiretrovirals in that setting. But honestly, if you look at like parts of Southern Africa, Western Africa, and even some parts of India, there's not a wonderful local supply chain of generics that are low cost and high quality, right? It's a very difficult issue, and for things like malaria or HIV. But now, if you add complicated molecules like antibodies and biologics, it becomes very, very difficult for companies to kind of start up. So, and I think in terms of what we could do as young professionals, that is a very real role for us. So I see a question from Kira. Oh, sorry.
Just regarding like the insulin, I think insulin might actually also be a very good case study, it being a larger molecule, a biologic,
yes,
and very complicated molecule to make. So
yes.
Sometimes it just starts with a case study and then can be expanded from there. Anyways.
Yes. So is Kira online? I guess she's not online. So this is a question I see from Kira. Don't work in this field, but I'm hoping to, so that's good. This might be a basic question. Is there enough awareness at the government level, health ministries of developed countries, that may have to subsidize the cost of access to developing countries? How many effective programs in place for this purpose? So this is a spot-on question, and I think I don't know the answer for certain, but if you look at the data, less than 1.7% of all overseas development assistance is earmarked for NCDs, and this includes access to essential medicines. So I think there is a growing awareness of the power of access to essential medicines, because the treatment of non-communicable diseases is also a form of prevention. It's a high-risk prevention and even secondary prevention. So for those who argue that NCDs are only a preventive issue and we can't afford treatment, there's a growing body of literature that shows that just as in the case of HIV, treatment is prevention. And so in certainly the case of heart disease, putting people on multi-drug regimens is very helpful to reduce mortality and morbidity and so forth. Whether, say, Norway or the United States wants to pay for someone's statins or breast cancer drugs in another country is a fundamentally different matter. And I'm not seeing that appetite yet. I think there is there's kind of this belief that it's not cost effective, that paying for someone's cancer treatment in Malawi might not give the biggest bang for the buck as opposed to something like tobacco control. So NCDs in general suffer from a paucity of global investment. And then when you try to argue for particular investment cases to trying to get things like access to essential medicines, in my view, has not been high up on the agenda. Aid funding has more geared towards preventive and structural policies. So, but there is aid funding, isn't there? No, so this is great. So there is aid funding, but it's not heavily earmarked for access to treatments for essential drugs. So the kind of party line is that it has not been earmarked for access to essential medicines for NCD drugs in particular. So the party line is that governments need to come up with ways to do this and scale up their national NCD plans sort of with their own existing health budgets. And this is my big beef, is that when I talk to, when we were just at the WHO, we talked to ambassadors and ministers, where's the resources? I mean, what can you do with, $19 per patient per year? You can't cover trastuzumab and breast cancers. You can't do insulins. You can't do, I mean, at some point something needs to change. And so I actually, and I might be in the minority here, but I do think we need to have a different sort of debate on aid funding that starts to cover NCD treatment. I think that discussion needs to happen at some point. And people have been very shy to talk about it because it's, oh, are we going to ask for too much? And no one wants to create a separate silo for NCDs, which I agree with. But I would argue for pooled procurement or ways of slightly amending what we have with the global funding. Exactly to your point. We have a global, right? No, I completely agree. So Dion is saying it's not exactly a sustainable model we want to go for. In the short term, we can have a global fund for NCDs, but in the long term, exactly. So I really do believe we sort of can't just have a vertical silo on NCDs, but we're going to need to expand existing infrastructure and existing toolkits to realize the right to health for primary care. But let me be clear. For the poorest 36 countries, I do think we need some startup capital or some resources to help move the needle a bit. Because right now, people are left to die. I mean, cancer is a death sentence, and while we debate financing and semantics, we're not making real changes. So either the cost of production has to go way down, we have an activist movement that scales up treatment and demands cost reductions and coordination, just like we did for HIV/AIDS, or I don't know. I mean, this is where we're at, because now we have these essential medicines that are deemed essential, but are not being made available or affordable to people.
Yeah. And I think that's also, to give another push for our Multiply Change campaign, really what we're looking to do there is to build our base of advocates and activists in different countries. So we're hoping that you can all support. What sort of teeth does the EML have? Not much right now. Right. I mean, it's a model list. And so really there's also so much discrepancy as to how countries implement it and use it in their national settings. Even at the WHO level, there's very little understanding of, what is even the process in different countries. Some countries how it works and some countries you don't. And there's a lack of transparency in many situations as to how these medicines are selected and who's responsible for those decisions. Sonia commented the NCD movement got started around diabetes in the Caribbean. So yeah, I mean, I think it's really important for us to go back to building accountability and building accountability that hasn't been there around the EML to create some sort of that make sure it has teeth. And Sunny's comment on the NCD movement being started around diabetic patients in the Caribbean. This is really a story where we often talk about the NCD movement having started from sort of this international policy level at the UN, and then we're hoping that it will trickle down to really people standing up and saying, we need access to cancer medicines, and that the governments will and insulin for diabetes, etc., so that their governments will do something about it and change it. And there slowly are movements in countries to change these policies, but it's not happening fast enough, and it's not specific enough. It's sort of general statements on what is happening, and exactly, we need more bottom-up activity. We need more people standing up in countries and saying, this is what needs to change. It's unacceptable that people are dying from cancer because they can't afford the treatment. It's unacceptable that people in the 21st century are having to undergo foot amputations from unchecked diabetes. And that's really why people in the Caribbean stood up and said, a huge portion of the health budgets in these countries was going to diabetes treatment. But why is it so expensive? And why, and then at the same time, they weren't seeing the results they needed. These patients were still suffering in huge ways, and so they stood up to their governments, which is called CARICOM, is the Caribbean body within the UN, and they brought it to the UN to say, diabetes is an issue, and then others stood up and said, well, other chronic diseases are also an issue, and so that's really where it's great that we have this UN declaration and we have these heads of state that committed to this action in 2011, but what's actually happening in countries? And that's where we need our members to stand up and ask those questions. So I'm just looking at, it happens every 2 years, periodic revisions of the EML, yeah. So yeah, it's revised at the WHO level every 2 years. In countries, it varies as to how often it's revised. People can feel free to jump in and talk, so tracking all the comments. Would it be helpful to have a toolkit for grassroots doctors? So we actually just developed a toolkit that we want to launch with this Multiply Change campaign, I mean, it'd be great to have, we'd be happy to have any of your inputs onto that before we more officially launch it. But Issue and others have been working on that, and and really focusing on essential medicines lists and utilizing that as a tool at the national level. And then, are there any tips from how we can engage oncologists and access to medicines? Maybe Sunny can answer that one.
No, this is great. I'm seeing this robust dialogue here on the side. I feel bad for whoever's talking because it's not as fun to talk. You have to. Sam, I sent this. This is a really cool story. So we actually petitioned to get imatinib or Gleevec on the essential medicines list, and I was really proud of oncologists, including those that discovered imatinib and some of the oncologists that worked on some of the clinical trials. They actually issued a kind of a call to action from oncologists on the unsustainable pricing. So that I would take a look at that, and we can sort of chat offline. But I think I completely agree that there is, and look, let's just talk about it. In the field of NCDs, there is a huge pharmaceutical market that private sector sees. So it is not surprising to me that sometimes NCD doctors, whether they're cancer doctors or heart disease doctors or diabetes doctors, both wherever they are, might have a relationship with pharmaceutical industries that hasn't been as scrutinized as it has been in the case of HIV/AIDS, right? If you think about it, this is a market that's expanding. It's an aging population worldwide, and these drugs, you have to take them every day for life sometimes. So that's a huge business opportunity if you're a pharmaceutical company. And now you have drugs that cost like thousands of dollars per year that people are really want to have. And there's no public outcry. There's no activist voice. There's no sort of demands. It is a landmine. I mean, it is not a landmine. It is a gold mine, right? So I think read that, and if we can get a health professional movement kind of started on this issue of pricing. I'm starting to see it in the States. Yeah, exactly. So Deanne's talking about farm free. And I don't know if you guys have seen this, but there's been a couple of things in the United States in the past 3 months. A guy named Martin Shkreli, I don't even know if I'm saying his name right. He jacked up the price of a drug by 7,500%. There was a report that cost of the same drug I mentioned, imatinib, was 600 times higher in the United States than it was in other regions of the world. So in the United States, at least, I know that Hillary Clinton, a Democratic candidate for president, and Bernie Sanders have come out with very strong policy positions on controlling drug costs. I don't know what the exact status of those are going to be in the future, but I know that activists and people that saw what Martin Shkreli and others are doing said enough is enough. It couldn't go forward. So I definitely, I'm seeing something as I sort of step back. I'm seeing another moment. Like in 2002, I think there was a moment when treatment activists said, 39 pharmaceutical firms sued Nelson Mandela's government for taking progressive measures to make AIDS medications low cost in his country. 39 companies sued him, right? And now with the case of cancer and heart disease, I'm seeing that same anger of patients saying, like, I'm left to die because I can't access this treatment. This is happening at Yale in the United States as well. I'm seeing it with hepatitis C drugs too. So there's something happening here where drug price is a huge issue, and it leads into the questions of research and development and so forth. But there is the outlines of a movement here, and I think the thing we need guidance on is how do we best strike, because we're a small kind of grassroots movement. Where do we strike best? I'm going to quit talking and read the stuff on the side.
That's a great question. So Kira's question, going back to the EMLs, was is it part of YP-CDN's efforts to try to develop a framework for follow-up once a drug is deemed essential, specifically a set of instructions that an individual country's health ministry can refer to for like a how-to procedure and distribute an essential medicine, or does that framework already exist?
It's a great question. So I can take a stab, and then Jordan's being modest. She's actually on a Lancet Youth Commission on Essential Medicines, and she's heading up the Essential Medicines kind of cluster. So I'll let her take a stab. For my side, we were just meeting with colleagues at the WHO. Oh, and so is Sam. Okay, I didn't know this. Well, this is perfect. Okay, good. So I can say that the EML Secretariat at the WHO used to have 25 people. Now they have 5 people. So only 5 people are managing the whole Essential Medicines List program. So even if there is a framework, and I do believe that there are a set of instructions for regions and countries, I don't know if they're enforced. I don't know if they're well known. I don't know if there's constant communication, not because of lack of interest, but I think simply because of lack of capacity. But maybe Sam and Jordan have more thoughts.
So, I mean, I think that it does come down to what Sunny said in capacity at the WHO level, and that there's a lack of funding for the department. But they do run, or have been running, and are going to really ramp up some trainings to ministries on sort of how do you set up your essential medicines list, and what should a selection committee look like. And these are expert committees that are, at least at the WHO level, composed of international clinical research experts, etc., and come together and evaluate the evidence that's submitted through petitions. And so, I mean, a real framework doesn't necessarily exist. I mean, the idea with the model list at the WHO level is that it's a model, and that each country will have to adapt and choose medicines based on the diseases that are most prevalent in the country and that have the biggest impact in their country. So really, it's difficult for a global list to say you have to be investing in all these medicines, because that some of those medicines just may not be required in some countries. But I think there's a lot more to be done just to have stronger civil society in different countries to work with their governments to make sure that these lists are A, up to date, and B, translated into action that results in medicines in the hands of people. I don't know if, Sam, you have any further comments before we move on to the... Sam? Okay. While you think, Sam, yeah, a bunch of us can make antibodies. So Diane's comment was, people here just seem to accept the high cost. Like, well, it costs a lot to make it. That's why it's so expensive. Education is needed to counter misinformation, at least on the cost of developing cancer drugs. And actually, that's where Kira would be good in commenting as well. She's doing her PhD in cancer biology. But I think on that comment of the side of the, I think we all recognize that it's really expensive to develop a medicine, but what the public statements from the developers always detract from is, how much it actually costs. And the study that came out of the Tufts University last year, that it cost $2.56 billion to bring a new drug to market, has been highly questioned, even by the CEO of GlaxoSmithKline and others. And so, really, there's too little transparency on how much it costs to develop a drug, and they, some of the from however many millions to billions, or my math is probably completely off, but there's a lack of transparency, and that's really where we need to make headway. And what I think is important for this movement is to also involve more scientists in the process. And so it's cool that many of us here actually have more biological research background, Deanne, Sunny, Kira, and myself, and thinking about that process and engaging the research community more in the impact of their discoveries, and thinking about their discoveries in a different way, and thinking about the patents in a different way, and how will that impact the access to discoveries, because really researchers go into research because they want to find a cure, or find a discovery that really changes people's lives. I haven't met a scientist that goes into research because they want to make a ton of money, because that's the wrong way to go. People who should know. Do you want to comment, Deanne?
Oh, I was just speaking towards the cost of drug making clinical trials. Is there a feedback? Sorry, I can't. Okay. Okay, now it's okay. Yeah, so it's extremely hard to find out the cost of clinical trials, just how much money goes into one trial. It's a project I've been trying to do for a couple of weeks, so it's I can definitely speak how untransparent it is. if you guys know, please send it my way. But it's, yeah, there's very, very little transparency. And it's funny because I was watching a couple lectures a while back, and given by some pharma folks, and they're very well aware that the 2.6 billion is not a realistic number. And they jokingly talk about it, and they're like, oh, obviously that's not how much it is, but this is the number we're pushing so that we can justify what they're doing. So, you know, for them, they have good reason to keep this number secret.
Well, we're already, well, now we're at about an hour since we started, about 10 minutes late. So I think we're going to wrap up from here, but I hope you all enjoyed the discussion. I certainly did, and I think it'd be great to continue and to bring in more people from different countries with different experiences into this discussion. If you do have any other points that you want to follow up with us on, please do email us. And I'm just going to comment, Kira said, that's a great point, Jordan. I don't think scientists think enough past the discovery itself to how that therapy will be scaled up and distributed to patients both locally and globally. There could definitely be more education awareness on the research side of the issues that exist. So that's one thing where I think we as YP-CDN are also well positioned to tap into different research communities and turn these nerdy biologist types that are us into activists. Great. So thank you all so much for joining. Yeah, technivists, as we with YP-CDN say, people who have this technical expertise, but really want to get out and make a difference and push social change. So, all right. We have many different technical terms that are being thrown around. But thank you all for joining us live on the Hangout, and those who were watching as well. Please do reach out to us over email at info@ncdaction.org. We're on Twitter at ncdaction. And you can also reach me at jordan@ncdaction.org. And we look forward to talking to you next time. Bye.